Christmas. Our ambition is to address current issues and topics and to talk to the whole universe, the whole world, and hopefully to be heard from the east to the west. Thank you all very much, the participants, and I'm going to name them one by one. Professor Johannes Bastian, Professor Ramesh, Professor Luigi Zagra, Professor Maziar Mohaddes, Dr. Guillermo Bonilla, Dr. Martin Butaro, and Mr. Syed Ahmed. Thank you, everybody, and welcome you to our webinar.
Thank you so much, Luigi. It's a fantastic introduction to this first webinar in this new series. Remember that last year we did a fantastic webinar series led by Professor Epinet. And this is a continued part of this fantastic work done last year. And we will start with this trauma topic. In this new era, I mean, we have tried to invite people from East. I mean, there is one speaker from India, Professor Ramesh, that will talk about current management of intertrochanteric hip fractures. Also, we will include Professor Johannes Bastian, will talk in this first part about what is new in pelvic and acetabular fractures. Next will be Professor Luigi Zagra, how to do a successful total hip arthroplasty after proximal femur fixation failure. And finally, in this first block, there will be Professor Mohaddes. So these 4 talks will be 8 minutes, and we have a nice discussion where you can do questions. Please send your questions through the chat that you have here about questions and answers. You have this chat here in your Zoom platform. So you can say your question, and the moderators will ask the speakers about that. So we can start with the first speaker, that is Professor Johannes Bastian from Switzerland. He will talk about what's new in pelvic and acetabular fracture. Professor Johannes Bastian, your time.
Okay, you can hear me?
Yes.
Yeah, good afternoon, everyone from Bern. So my topic is about what's new in pelvic and acetabular fracture, rather an open question. And the question is how to approach that one. So new means having recently come into existence in use or focus. And to address this issue, we can check for publications, for annual meetings, societies, and committees, and also find or check for new releases of the industry. But the question is in which kind of topic? So there's a vast area of topics, as you can imagine. So we have the fracture and the patient understanding, decision-making, access and reduction of fractures, fixation of implants, and training and teaching are topics. So I would like to give you at least a selection of news. First for the pelvis, and then secondly for the acetabular fractures. So in terms of detection, here's a publication showing the use of artificial intelligence in pelvic fracture, radiographs using X-rays, of accuracy, sensitivity, and specificity is at least a little bit enhanced, but without any statistical significance. So the AI performs very well. And this is the reason that could be considered as a tool to rule out fractures, let's say like a sort of second reader, or in some busy places to support during night shifts or in the emergency department. And at the end, think about rare rural hospitals where you don't have any radiologists on site or even not a CT scan. So this could be very helpful. For the OTA meeting last year, there's a review of recent advances in diagnosis and treatment in pelvic ring injuries. And here I would just like to focus on one. So you know that the lateral compression fracture types are the most frequent ones, up to 60%. And there is a controversy still about to operate on them, yes or no. And here you can use that algorithm showing that you can have an examination under anesthesia to check the amount of displacement. And if this is more than 1 centimeter, then you can go for pelvic fixation. And the algorithm succeeds with a second check for displacement at the anterior side. And if there is still also more than 1 centimeter, then you go also for fixation at the anterior pelvic ring. This is a new publication showing something very interesting. So you place the patient in lateral decubitus position for the so-called lateral stress radiograph. So basically you do the same but without anesthesia, and then you check with or without stress for the distance between the teardrop as an indicator for the amount of displacement. And if you do so, they showed in the publication that there is occult instability in at least 63% of the cases, and this was associated with older age. Think about fertility fractures. In cases with these Nakatani type 1 Rami fractures, which are very close to the symphysis, so probably the inguinal ligament is also injured for some tension band effect, which is gone, and in Rami fracture comminution. And in these cases, it took longer to ambulate. They had longer hospital stays, and the patients were more likely to require rehab facilities. In terms of fixation, there was a release of this curva fix system as a new surgical technique and implant device published here. And this is the bendable auto screw, which is an intramedullary flexible device. So the flexibility can change to a rigid construction. And the idea is that you can take the shape of the curvature of the pelvic bone, and if you have two different linear corridors, which are non-linear, then you can connect them, and by this you can increase the length of the implant, which you can fix so it gets rigid, and by that you increase stability. And the idea basically for sure is to enhance early mobilization in patients with fragility fractures. Let's come to the acetabulum. So an increasing issue are periprosthetic acetabular fractures. So this is a series of cases we had to revise and burn of these acetabular fractures, and they also modified the Propositive classification, as you see on the top left, with intraoperative fractures during cup insertion or cup removal. Then you have traumatic, spontaneous, and pelvic discontinuity cases. This is a case from some weeks ago. So this is rather a personal experience. Maybe the faculty shares this experience. We see more and more neck or femur fractures which are treated instead of a hemi with a total hip, because people get older, the bone stock stays poor, and then you go for a total hip. But you have the sharp remus, but you have not an orthopedic joint with a sclerotic socket. And then this happens, that people ream too far. In this case, too far proximal and postally, so it failed and it came to this kind of fracture, which I had to revise using the principles for this kind of fracture care. It's the Periprosthetic approach from the anterior side, fixing the anterior column, going for surgical hip dislocation to fix the posterior column, to use a bone graft and to use an augment to restore the center of rotation in the trabecular metal cup with a double mobility cemented in that cup. We published 2 years ago predictors, or let's say how to identify this kind of risk for medial protrusion already intraoperatively. If you can check intraoperatively, then avoid more than 50% of medial protrusion. You can see that angle, the yellow angle. If this is more than 90 degrees, you're almost at 50% according to this algorithm. You can check in the publication. Okay, this is a nice publication, okay, already 3 years ago. So with an algorithm, if it fails, the key principles are the question. Is the fracture displaced? Is the implant stable? Yes or no? Is the bone lost? Yes or no? At the end, you will have the 4 R's. So removal of the cup, reconstruction of the columns, restoration of bone loss, and re-implantation of the cup. In terms of classification, recently there came up with this quadrilateral plate fracture classification. You can see the illustration on the right side. So this is a new type of classification, rather with the columns from Lettermel, starting from the quadrilateral plate. If the quadrilateral plate fracture is extending in the anterior column, or in the posterior column, or in the AP anterior column, posterior column, or if it's an isolated type of fracture at the quadrilateral surface. In terms of fixation or I found this innovation prize of the pelvic expert group from the AO. And they got this prize for this new plate. As you can see, it's a combined plate. The innovation is that there are more options and there's more surface of the intra pelvic quadrilateral plate covered with the plate for fixation. And last but not least, I would like to share these videos with you. This year and already last year with the Amsterdam Striker Pelvic and Acetabular course, I'm also a faculty. We had we were lucky to have this non-Maziar company with us. So this is quite innovative because you can have case discussions in a VR setting. So you can jump into the factory, you can run around the factory, you can discuss how to reduce, how to revise failed cases, how to fire screws, and so on. This was quite fun. Thank you for your attention.
Thank you so much, Professor Bastian. It's an amazing presentation. Thank you for stay in your time. And the next speaker will be Professor Ramesh from India, and the title is Current Management of Intertrochanteric Hip Fracture. Professor Sen.
Good evening, everybody. The current concepts as we go on forward, we must appreciate that if you look at that data of systematic review, it says the declining incidence of hip fractures. But when you see the growing aging population, actually the number of hip fracture is likely to double in next 20 to 30 years. And we understand the mortality is reasonably high. As far as the newer version of the classification, this has come, it has actually highlighted that in A21 fractures, a large banana-like fragment posteriorly is a corner that constitutes the posterior greater trochanter crest, and the lesser trochanter is an important part in the reduction of it. The standard reduction can go in most of the cases, but lately we had to have more things like manipulation, as in this case, for the reduction by external application, or we might be using a minimally invasive technique to get the reduction, or as per the literature also says a lot in the recent literature, we might use those kind of a circlage wire as a reduction tool and then put the nails into it. What is the kind of reduction? Now, we appreciate that if the medial wall of the femur shaft fragment acts as a buttress for the medial cortex of the neck fragment, which we call as positive reduction. But if it is not, as can happen in some of the cases, that will be that the head is going in, the neck is going inside the trochanter, then it's a negative reduction. Ideal is that it should be positive reduction in both AP and lateral view. If it is a negative reduction start with, our aim is to get the reduction to be a positive reduction before we start putting the guide wire. And that is what it has to be. The conventional fixation has been a dynamic hip screw, and we understand its angular construct and everything. The problem is it has to have a lateral wall to act as a buttress for the fragments of the neck. And it is limited to stable fractures, and the hardware could be an issue. And defining its position so that we look for its cutouts, the tip apex distance is the most widely used criteria. Statistically, in multivariate analysis, it has not come up to that level, though in univariate it is okay. The other method proposed include Cleveland zone system or Parker ratio, or this Kelkar reference tip apex distance, which has been found to be a much better. And if you look at the recent literature which has come up, this is a much better predictor for the cutout as compared to the classical tip apex distance. If you look at the NICE guidelines or the American guidelines of 2015 or the recent case studies guidelines in 2022, they recommend DHS. But let's know that all the literature subsequently that has appeared does not say. So all this meta-analysis does not give a superiority to the DHS and rather even to the Ahmed nail also. One of the reason is because DHS depends on the integrity of the lateral wall, and if it is absent, there is likely to be a reasonable collapse in the fixation. One of the other options which has been used as a plate fixation is a proximal femur locking plate. It has its own issues, but then there could be selected cases, just like when you can't put a nail due to the marrow being very narrow or reverse oblique or fracture exiting at the GT level, can be used in those specific indications, especially when you want an anatomical reconstruction, and that too relatively for a younger population, as we have done in this case, it could be of some use. But the most common implant which is used is a fellometry nail. We understand that the short nails are better because they have less reoperation rate, less radiation exposure, less blood loss, and less operating time. And this is supported by all the literature. But in the Asian patients, and rather to say in our Indian patients also, the diameters don't match with the short femur. And so there are changes which have been made to all the implants which has come into the Asia. We do have PFNA now available, which takes care of the problem which was there used to be the impingement. And the another good thing which has happened with the TFNA is the option of putting a cement into that osteoporotic femur head, which makes the stability much better, as has been seen over here in the recent publication. And it's also found out that the complication rate is not there due to this cementation. It's a very rare kind of a complications. It is recommended in the day of today that long nails can be used in a specific conditions when we have a primarily lateral wall fracture or a subtrochanteric extension or a very wide medullary canal or a large coronal fracture. It can be done, just like in this case, we have used a long TFNA in this case. Now, whether to lock in and lock is another decision. The option, the meta-analysis says that we have a difference in both the things of getting a locking because it increases. So we should have a rational decision making as per this literature, that after the fixation proximally, we must look at the stability. If it is stable rotationally, we should not put distal lock, but if it's unstable, we must put a distal lock. There's another system, Gamma 3U. It is a new system. It's one of the modifications which is there. And there is another system called Intertrochanteric system also, which is supposed to be safe and effective in this population. But when you compare all these systems as per this literature, it has been eventually found that PFN is the least intraoperative blood loss and has the shortest hospital stay among all of them. There are people to say arthroplasty. But again, if you look at all the meta-analyses which have appeared, it does not give superiority. Rather, one of the meta-analyses still says that internal fixation with the proximal femur nail is superior to hemiarthroplasty. There could be some benefit of early post-op weight bearing or a shorter hospital stay, but overall internal fixation has a shorter operative time and a lower blood loss, and that is all this analysis says. What's the future? This article which says that if you look at the literature which is coming on trochanteric fracture, it is steadily on the rise. And likewise, when you look at the profile of areas in the trochanteric fracture, whether it's a fixation, whether it's arthroplasty, whether it's a mortality, osteoporosis, everything is being searched for. So we do feel that with the available evidence of all the meta-analysis of RCT, we don't have any specific superiority of DHS or cephalometry nails or arthroplasty, but cephalometry nails have a better outcome in respect of operative time, blood loss, locking only to be done if it is unstable, and definitely there are new designs which do offer some advantages in that kind of a situations. Thank you.
Thank you so much, Professor Ramesh. And let's move to the next speaker from Milano, Professor Luigi Zagra, with the talk titled How to Do a Successful Total Hip Arthroplasty After Proximal Femur Fixation Failure in 2024. Luigi, please, go ahead.
Thank you, Oliver, for putting together these great events of the new webinars by the European Society. Thank you, Eleftherios, our president, for the invitation. It's a great pleasure and honor for me. So this is the topic. So what about these are These are my disclosure, not related to the topic of the content. So what does it mean a successful total lip in proximal femoral fixation failure? Above all, primary stable fixation in the proximal femur, restoration of hip biomechanics, and most of all, prevention of complication in these which are most fragile patients. This is a demanding procedure with a longer length of stay for the patient in the ward, with an increased risk of infection, dislocation, and intraoperative fracture during the procedure. They look, in most of cases, more like a revision than like a primary total lip. And measures should be taken to prevent such complications. So let's start to prevent at least the intraperiprosthetic fracture. We know that we have a lot of stress risers, so let's choose the good type of fixation. Cement stem is definitely an option. We use it in general in cylindrical canal, in parotid bone, in thin cortex, in older age, but even in post-trauma and or post-surgery cases. Standard cemented femoral stem have shown to be reliable and cost-effective in such cases, and it is not necessary to bypass the distal screw hole as long as the bone holes are covered by cement. So let's look at some cases. We can manage in an easier way femoral deformity, post-traumatic one. This is the case, female, 64 years ago, a gamma nail 10 years before, now arthritis, painful. This mild varus can be properly controlled and accepted with the cement stem. This is a 5-year follow-up. In the meantime, the lady is operated in the other side. So you can manage this. Consider when you do this approach and you try and convert to the total lip, 2 tricks. First of all, the insertion, point of insertion, of introduction, the blue arrow of the nail is not the same of the stem. So be careful, don't go starting your procedure along this hole, but find the good canal. For finding the good canal, it can be tricky sometimes to find it because you have piece of the neck in between, especially if you have a DHS, even more than with the nail. But anyway, the canal can be closed with this fragment, so you have to take into consideration these 2 tricks. Primary preparation and the cementation is okay. Sometimes we say, don't cement if the nail is inside because the canal is not good for interdisgitation. But that's true. That's not true. The nail is usually smaller. You can have a good cementation proximally because the bone can be good there. And of course, you can do it properly, reducing, as I mentioned before, the risk of periprosthetic fracture. You have, of course, during cementation, to control the holes, you can leave some hardware in situ, such as the cables that are in this case of a DDH, and you can control with the bone graft. With your fingers, that can be also easier, the holes for doing a good pressurization of cementation. Of course, one other major complication is of dislocation here, because we have poor soft tissue, previous care. We have to control this. An option is to use a dual mobility and to control the offset. A lot of these fractures have a high offset, so control the offset with a high offset stem. Infection control is another big issue, because the third main big problem at risk is infection. This is a female. She was operated 3 years before for an intracapsular fracture with a fixation. She came with a slight ESR elevated, CRP was negative, but I don't know why, but she did a label leukocyte bone scan that was positive. So definitely this is for a 2-stage, remove the hardware. There was a staph hominis that was positive for that, do antibiotic therapy, and then after the stage hardware removal, we go again for a hybrid concept with the cementless cap, which has been recovered with this gel, you know, the DAC, with the antibiotic, vancomycin, and then antibiotic-loaded cement for the femoral side. Another case can be even more tricky. Also, even when you see a rapidly narrowing of the joint space, and when you see difficulties in the healing of the fracture, always suspect an infection. This guy, during an epileptic crisis 6 months before, had a fracture. It was fixed, elevated ESR, elevated CRP. There was pus everywhere. This is propione access, and this is for a 2-stage procedure. Of course, we can also use cementless stems in case of good bone quality, according to the femoral shape and supporting metaphysis, including short stems in some cases. But the length bypassing the screw holes is important, and we can also use long revision stem in case of proximal bone loss. We use this according to the door classification, according to the shape. But be careful that every time the metaphysis is in some way affected, even if supported. This is a young lady. She was fixed for a medial intracapsular neck fracture 14 months earlier, not yet healed. She was replaced, putting the screws in compression with bone marrow stromal cells inside the graft, and then she healed, but she went into a necrosis. Now she needs a total hip with a total P. Be careful, you have holes here. If you use a stent with a very big taper and proximal fit, you can have problems with the screw there. So this is the Zweimüller type stent with this type of fixation, a reconstruction of the anatomy. You can have also proximal femoral deformity. This is a post-trauma in the childhood of this guy. He was operated with a typical straight stem on one side, very helpful, but use a straight stem on this side can be difficult. So you can play, manage, do a pre-plan. This is a good option for a short stem. The short stem can tolerate in this type of various positioning. So again, this is another choice that you have to take into consideration. You can go to some other global and major deformities, not just of the proximal femur, but of the whole femur. This guy had the polytrauma 24 years before. He already had the Judet for stiff knee, now pain, severe limping, hip and hip fixed flexion. And you can see in the lateral side how there is a complex deformity all around the femur. So we can manage it with a cementless stem, but we need a short one, a cortical one, properly seated in the good position, remove the screws because of the fracture of the acetabular side, and the guys can have a functioning hip again. You can also find and face some more difficult situation, such this one, non-union of the diaphyseal level, non-union at the neck level. You have to manage both. Of course, you can manage with the long stem, but another option is that you can manage separately, removing the hardware, curettage and of the diaphyseal non-union, cementless total hip, managing the proximal femur as a whole part because the fracture was in the neck level, bone grafting of the whole femoral in the non-union at the level of the diaphysis, and then fix as a periprosthetic fracture. This is 6 months post-op, no pain, no more leg length discrepancy, and this is a 3 years follow-up with a good recovery of the guy. Good radiological, a clinical outcome can be achieved either with long stem, especially when you have proximal problem. But be aware, in these cases, there is a huge amount of possibility of intraoperative fracture and greater trochanteric avulsion. Of course, in case like this, broken proximal femur, the nail is broken over there, there is the metaphysis totally not supported. You need to use a revision step with a distal fixation. These are difficult cases, and you have to rebuild anyway the anatomy, putting the greater trochanter in the good position. But be careful when you use a long step. Look at this guy. He was treated again. There is 2 fractures at the level of the neck, at the level of the diaphysis. He was fixed, not healed, so they went to a new fixation. This placement of the proximal fracture, so they say, okay, we can treat both with the long stem, but the long stem went to a 3-point fixation. So it means that this stem, in some way, it's always painful, it's subsided. So it's better to remove now that the fracture is healed and go to a standard stem, managing and controlling that there is not infection. So what in conclusion? Cemented fixation is a valid option in most cases. This is experience. You have to control the canal preparation properly, especially to have a good indentation of the cement and control the extrusion of the cement through the holes. Cementers for the young patient in case of good bone quality and supportive metaphysis, revision stems in case of proximal bone loss. But be careful of the risk of periprosthetic fracture. But above all, prevent the complication, include the use of dual mobility, stage hardware, or spacer 2-stage in case of suspicion of infection. Thank you so much for your attention.
Thank you so much, Luigi. Fantastic talk about how to manage this very common problem in many of our departments. And we will move now for the last talk of this first block. Professor Maziar Mohaddes from Sweden will talk about the new frontiers in hip periprosthetic fracture. Maziar, your time.
Olivier, thank you very much for the kind invitation, and thank you, Professor Tsiridis. Good afternoon from Sweden. Good morning to those of you who are at the east, and good evening for you on the west. My name is Maziar Mohaddes. I'm an associate professor at Gothenburg University, working in a hospital in Sweden called Hässleholms Hospital. I do have some disclosures. None of them, I believe, are relevant for the case of this presentation. And I would like to also acknowledge my co-workers and professors who have been crucial for my career, but also the specific presentation, Dr. Georgios Chatsigouros. I was asked to talk about the new frontiers, and I'm quite certain that those of us that fail to learn from the history are doomed to repeat it. And therefore, I will be repeating parts of the history for you and then present a few slides on possible fractures in periprosthetic femoral fractures. So periprosthetic fractures are most commonly encountered in female, about 90% of all cases, and 10% in acetabulum following hip arthroplasty. Intraoperative fractures are most common with uncemented THAs. The incidence is described to be 5.47 for intraoperative fractures, and for cemented THAs, only 0.3%. For primary THA, the incidence is described to be 3.6% in total, and for revision THAs, astonishing 21% for intraoperative fractures. Postoperative fractures occurs in less than 1% of primary THAs and 4% in revision THAs. And majority of these fractures are low energy trauma, the postoperative one for you. Looking into data from the Swedish arthroplasty register, the yellow bars shows you the increase in the number of primary operations being performed in Sweden, and the drop here is due to the COVID pandemic, where elective surgery was cancelled in most of the hospitals. You see also that if you look on the blue bars and the black bars, which are first revisions and multiply revised patients, that the proportions are not moving on. And in fact, if you look on the proportion of the surgeries being performed in Sweden, the proportion of primary cases is increasing. Meanwhile, proportion of revisions is decreasing. If you look into specific reasons for hip revision, you see a decrease in aseptic loosening. So the proportion of revisions being performed due to aseptic loosening is reducing in Sweden, but you also see a clear increase in infection and a trend to increased revision due to periprosthetic fracture. This might probably be due to an increased use of uncemented fixation in Sweden during the same time period. This is a very beautiful paper. We looked into the surgical treatment of Vancouver, based on Vancouver type, periprosthetic femoral fractures from the Swedish arthroplasty register. It was about almost 1,400 fractures being included in this analysis, and Vancouver type B fractures were chosen. And you see the proportion between Vancouver B1, Vancouver B2, and Vancouver B3. We analyzed the patient survival in relation to Vancouver classification. And as you see, there is a large mortality in these patient groups. A 5-year mortality was about 50%. And it was a significant difference between the different fracture types, with B2 having the highest risk of mortality, patients having highest risk of mortality. We also looked into the 5-year implant survival, and you see that the B1 fractures had the lowest implant survival, with the B2 not requiring as many, and C not requiring as many surgical revisions. So the classification, which I hope is well known by most of you, is the most used one is the Vancouver classification. And this historically has been described as a key to treatment. And I would like to encourage you to have a thorough look on this effort open review paper that beautifully describes the planning, the having the trauma arthroplasty skill presented when you are treating these periprosthetic fractures, the importance of ruling out infection in these fractures as described by Luigi for the failed hip fractures, but also having a plan A, plan B, and plan C. So the traditional management of periprosthetic femoral fractures is that the classification decide, but there are upcoming evidence that patient comorbidity and functional level might play a role in your decision on how to treat these patients. Obviously, implant stability is important, and although the traditional Vancouver classification describes when the implant is loose or not based on Vancouver classification, this is probably not fully true. Another important factor to consider when you are trying to make your decision on how to treat the periprosthetic fracture is the implant type being used, and I will get back to you in a couple of minutes on that. So most literature suggests non-operative treatment for the type A fracture. If you have a non-union for the AG fracture, then you can always do a surgical intervention trying to refix the greater trochanter, although the results in the literature are not promising. What you need to be aware about is that if you have AG fracture due to osteolysis, not very uncommon with some of the cemented stems, you actually need to revise the stem because the AG fracture is due to the cement loosening. For type B1 fracture, vast majority of the literature suggests open reduction and internal fixation. B1 fracture is when the stem is stable. For B2 and B3 fractures, the traditional treatment is to revise the stem and open reduction, internal fixation when needed, depending on the stem you are using for your revision. And for type C fractures, there are no major controversies. Open reduction and internal fixation is the treatment of choice. So this is a beautiful paper looking into the current practice. This was sent out by Martin Thaler and co-authors to the European Hip Society members. They looked into treatment of periprosthetic fractures following hip arthroplasty, performing an online survey for the members of the European Hip Society. 132 members answered the survey, and 20 cases of periprosthetic fractures were presented to the members of the European Hip Society. And the surgeons were asked to answer questions regarding classification, treatment, and postoperative treatment protocol. I will just show you some data on the suggested treatment, where quite a few of the European Hip Society members suggested using ORIF for the AG fractures and AL fractures as well. For the B1 fractures, majority suggested using ORIF. For the B2 and B3 fractures, revision stems with plating or cabling was suggested as the treatment choice. And for the C fractures, vast majority suggested ORIF again. Here is another interesting paper, 2023 in Bone and Joint Journal, where they performed a multi-center comparative analysis, and you have the QR code if you would like to scan that and read the paper for yourself. They looked into fixation versus revision surgery for periprosthetic femoral fractures in total hip arthroplasty with a cemented polished taper slip femoral component. So this is a very specific cemented stem being used and in need of revision. They included data from 5 centers in UK, and the primary outcome was 2-year reoperation rate. They did also measure time to surgery, transfusion requirements, critical care requirements, length of stay, and 2-year local complications following the revision. What they did show in the 317 periprosthetic fractures with a follow-up of 3.6 years was that about 42% were Vancouver type B1 fractures, B2 was in 54%, and B3 was in 4% of the cases. About half of the patients, 47%, were revised. Meanwhile, 53% were operated only using ORIF. And the 2-year reoperation rate was 15 versus 7%, favoring ORIF, which is quite surprising. They did analyze all Vancouver B fractures, and the solid line here is the implant survival for ORIF, and the other line here is for the patients having a revision. And you do see that the risk of revision is lower if you ORIF the patients rather than revise the patients. They also looked specifically into B2 and B3 fractures, and you see here that the risk was quite similar for having a second surgery done, regardless of if you were operated with ORIF and revision in B2 and B3 fractures, if you had the periprosthetic fractures following a cemented polished taper slip femoral component. Their conclusion was that revision surgery had higher reoperation rates, longer surgical waiting times, higher transfusion requirements, and higher critical care requirements than ORIF in management of periprosthetic fractures for the specific stem designs, and that ORIF was a safe option providing anatomical reconstruction was achievable. In summary, there is a discrepancy between evidence and practice in treating Vancouver A fractures, as illustrated in the tables I just showed you. The fracture classification alone should not determine the surgical method for Vancouver B fractures, and open reduction and internal fixation is a viable option for selected Vancouver B and B3 fractures. Thank you.
Thank you so much, Maziar, for your fantastic talk in this update. So I invite all the speakers to join for discussion and Professor Tsiridis to lead this discussion, and we will introduce the questions from the audience. So, Professor Tsiridis.
Yeah, well, let's start. We don't have very much time to go, and I think I don't know if Johannes is around for the pelvic and acetabular fractures. But if he's not, we can start. Oh, here he is. Hi, Johannes. Right. Let's go and start and take it from the beginning. Do you see any? You presented a couple of modifications of the classification systems. Do you see that this is going to change our practice in terms of treating the fractures? The usual way, or is it going to be of any help to reclassify the fractures?
Of the acetabular fractures you're talking about? No.
Yeah, exactly.
So. No, I don't think so. At the end, you have to check for the articular surface. We have more to check for impaction of the articular surface and to think about the column principle. And still the golden standard is the Latinal classification, enhanced by CT scans. But for very rare cases, we can use also artificial intelligence to find rare fracture types. But at the end, you have to define do you approach a fracture from the anterior side, from the posterior side, or both. Do you go for simultaneous or sequential type of surgery? And also in the plate system, there are several other options, okay. But there has been more than years ago a combined plate pre-shaped, anatomically pre-shaped from another company, which is very close to the system now. So
very quick question.
You have to be able to fire the screws as the plate suggests on the sawbone.
Right. Very quick question. Do you use in your practice at all hip surgical dislocation for combined femoral head fracture and the sort of acetabular fracture? Is it a way to approach? This is a rhetorical question for the audience. Hip surgical dislocation to enter the joint and at the same time control a Pipkin fracture?
Yes, I did 2 weeks ago. So 4-type Pipkin fractures combined the posterior wall or some post-traumatic dislocation, you can go for surgical hip dislocation. It's very rare that we do just only an anterior approach for the fixation of the Pipkin component or even to treat it conservatively. Most of them are by high energy trauma. They are combined procedures to go for surgical hip dislocation.
Well, I had the same experience, Johannes. I'm actually using now the hip surgical dislocation, wonderful way to preserve the vascular supply. At the same time, you can address the anterior column from inside out and reduce it. So, wonderful. Shall we move to the second? I'm sorry, we need to do it very fast because Oliver gave me only 10 minutes to address 5 presentations. So I've got 2 minutes for each one of you guys. So let's move on to Professor Sam. So DHS, I had quite a long time to see a DHS in my practice, although during my early days in the UK where I was trained, we used to do a lot of them. It was the bread and butter of our practice. Do you see the DHS coming back?
No, it's not coming back. But they're the people maybe for the older generation who are still sticking to it. They have not come out of it in their practice. And the latest, all young surgeons are now only for cephalometric nails. Their DHS is going out. And let me just add, we are looking at the facility, we are looking at the expertise that if we have to right now look for one procedure, it has to be cephalometry because it can go for every fracture possible while it cannot be the other way around. So I think we are okay with these cephalometric nails now.
The second question, I've got a significant allergy when I see this sort of complex locking plates wrapping around the greater trochanter going all the way down, too many locking screws, etc. We know from the mechanics that very many locking screws do not do well. What is your experience?
Obviously, considering again in the trochanteric fracture, all these plates are for very specific indications, not otherwise. Yeah. It is just like as I was telling about the PFLC also, the only when you cannot put a nail, it is so bad or so constricted or so narrow, maybe one of those indications. And especially when you want an anatomical reconstruction around the trochanteric area, could be that indications. Otherwise, surely it is not in the first choice.
And last question, but very important, I guess. I saw in one of your x-rays this lateral displacement of the proximal fragment. Make a point. We need to be extremely careful. Reduce first and then nail. Is it correct?
Absolutely. And that is what I highlighted in all my examples. It is the reduction make it a positive reduction, and only thereafter start doing your guide variable.
So exactly this is the point. Open the fracture area, reduce properly, put a cable, a circular wire, or maybe a head groove to maintain the fracture position, then nail it down. Thank you very much, Professor. Now we're moving to my great friend Luigi. Luigi, what some amazing cases. I was really surprised and impressed with the complexity of the cases. Now, I know that both of us, we like cemented hips, and we believe, strongly believe, that when we're dealing with a deformed femur or osteoporotic femur or some kind of not proper sort of columnar femur, we need to go cemented. But give me a little trick. You said when you go into the femoral canal, you should not go through the entry point of the nail. I mean, in my experience, I know that the entry point is too far lateral, but has destroyed the greater trochanter already. Now, by trying to open the window more medial, then you destroyed probably the greater trochanter. Give us a little tip.
If you go to the hole, which makes you immediate as a thing, you go in the wrong way, because you go through the muscles. Usually you put the nail is put through the gluteus medius, so you go in the wrong way. You have to respect this part, of course. You know, another trick, which is very important, is first you dislocate the hip, then you remove the hardware, and then you relocate. Never remove first, because you can displace everything. This is the
great point. Great point. First dislocate to make sure it is dislocatable.
Yes, and then relocate is if necessary, remove the hardware, and then go on. But the preparation of the femur is according to the type of stance you are using, which is not a nail. You have to cut it. You have to cut the neck where you can. You have to remove the piece of neck that usually goes in between and is closing the canal in approaching distally. And when you remove this piece of bone, and usually you remove more than you remove in a standard primary, you can have access to the distal femur.
Very quick second question, very important. Gluteus minimus, gluteus medius, usually damaged from the previous nailing. You see a defect. Do you use a kind of reconstruction technique like leeward side, bringing forward a flap of a greater trochanter of gluteus maximus, something like that?
No, I don't. I think that the surgery is already demanding surgery. I have no great evidence in my experience about the result of that. I prefer to use a dual mobility in order to improve this stability of the implant, and especially restoring the biomechanics, which is especially an issue of offset and good anteversion of the neck.
Great presentation. Thank you very much, Luigi. Now, we're moving on to my great friend, Maziar Mohaddes. Great talk. You know, I've got a great interest on periprosthetic fractures. They have contributed significantly to the literature. And I'm a little bit surprised by this paper from the UK. So they fix B2 and B3 fractures, cemented fractures. How come? I mean, do you accept that? If the cement is broken, how can you fix? I mean, I can understand fixing, yeah, me too. I can understand fixing the bone, but fixing the cement is something unique. I can understand cement revision, but fixing a broken cement mantle, I think Martin will jump off his chair.
Professor Tsiridis and Professor Zagra, I did see you doing the thumbs down. I can't really show the thumbs down. There you go. For the sake of the debate, I chose not to show traditional treatment, which is highly evidence-based or eminence-based. That paper is quite astonishing. I think my personal opinion after reading that paper and your papers, Professor Tsiridis, and listening to your marvelous speeches on periprosthetic fractures and how to reason, is that if you have a polished stem where the cement mantle is intact, then you probably are safe doing your ORIF. I know for a fact that there are colleagues in Europe actually proposing using ORIF with sarclage or plating for B2 or B3 fractures, even if there is an uncemented stem. I don't feel very comfortable doing that, because if you have a B2 or B3 fracture, vast majority of the cases, the stem is loose. So I think you are right, Professor Tsiridis, pointing out that if the cement mantle is loose, then you should definitely revise the stem and not only use cyclage. what they showed in this retrospective analysis of 5 UK centers, I believe, depends on that the cement mantle is probably intact in quite a few of these polished stems, aka Acetabular, being used.
I mean,
please speak on.
Yes, there is a question from the audience. Christian Pankowski asks you, Maziar, how should we decide if a Vancouver V3 fracture is more suited for a long stem and circlage wires or if?
So based on the obviously observational data, register data that are available, I would probably consider doing that for younger patients. We do see in the Swedish arthroplasty register that use cemented long stems for that kind of fracture benefits the risk of revision. Meanwhile, if you are less than 75 to 80 years of age, you probably benefit from using a longer uncemented stem and then cyclage or if.
Thank you. I mean, Eleftherios, I'm sorry, time is run out.
Oliver, I think he's very mad at me, but I think I will meet up with him soon, and then he can give me some more spanking on this topic.
Oh, I know. I mean, maybe next time, but we are virtual, we're in a webinar, and we need to move forward to the next block. Thank you, guys, for all the stuff.
We watch you, Luigi.
I mean, I'm dead. I know. That's my role. No worry. So let's move to the next block that is so exciting one. That is a crossfire between two surgeons that are European Society members from Latin America. And they are going to do a crossfire about femoral neck fracture, fix or replace. So they are from Colombia, Guillermo Bonilla, and from Argentina, Dr. Martin Butaro. So first of all, Guillermo, you need to talk about your position. And after the two talks, we have a very short discussion, and audience can vote the winner, and the winner will get a huge hour. So please stay tuned and vote at the end of the discussion for the winner of this crossfire. So go for the first speaker, Guillermo Bonilla from Colombia. Guillermo, your time.
Thank you, Oliver. Hello to everybody. Good morning, good evening, good afternoon, depending on where are you. And I was assigned by the organizers the difficult task to convince this audience to do more hip replacements in femoral neck fractures. So I changed a little bit my task, and I will convince you to do more hip replacements. I mean, to replace the femoral head in more patients. My name is Guillermo Bonilla. I work in Bogotá, in Hospital Universitario Fundación Santa Fe, Bogotá, and Universidad de los Andes. So these are my potential conflicts of interest, nothing really relevant to this presentation. And traditionally, we have had these four groups, In the past, I can still remember this classic paper by Marka Swinkowski, and then some 20 years after, this new paper kept the same four groups, and these four groups assign patients to treatment depending on the displacement of the fracture and the age of the patient. And for purposes of this talk, I will accept that these three groups will keep them like that. Not that sure, but for purposes of this talk, we'll do it like that. And I will focus for this talk on the young patients with displaced fractures. In this, historic perspective, we have been performing internal fixation in most of these patients with very questionable results. I will show you a couple papers. This is the FATE study, a huge randomized trial comparing internal fixation with sliding hip screws or cancellous screws. More than 1,000 patients, follow-up of 24 months, mean age 72 years old, and 32% of the fractures were displaced. And even in this small proportion of displaced fractures, the reoperation rate at 2 years after surgery was 21%. And if we add the conversion to total hip and conversion to hemiarthroplasty, it was 15% of patients that were converted at 24 months after the surgery. Second paper, this paper shows us pretty much the same with a little bit longer follow-up. At 8 years, 30% of the patients underwent an internal fixation, had been reoperated, and 14% of them were converted to total hip arthroplasty. So these results are far away to be good results. Why do we keep ourselves doing this? Because in the past times, the standard of care was the conventional polyethylene. We used small diameter heads, so we had where we had osteolysis, and we had really high rates of revision during the first years for these young patients. But this was in the past. During the last 25 years, we have had several game changers for these young patients. Now we have highly cross-linked polyethylene, we have improved ceramic pounds, we have improved stents, we have larger diameter heads, and even dual mobility components, which could solve some problems in this group of patients. And these innovations, especially the highly cross-linked polyethylene, have changed the outcomes in this young patients population. If you see at this paper shows us more than 90% of survival at almost 20 years after the surgery. So if we accept that nowadays we have near 90% survivorship at 20 years, this is a very good result for young patients. So the question now is what to do when we face a displaced femoral fracture in a young patient, a fixation or an arthroplasty. We can do this decision in two ways. First one is to keep the religion of preserving the femoral head. The other one is to look at the evidence and make decisions based on this evidence. For me, this second option should be the best option for every patient. So, which are the relevant questions when we are trying to make this decision? We need to take a close look on the early postoperative complications. We need to take a look on the short-term reoperations, on functional outcomes, and in the mid and long-term failures. So during the next 4 minutes, I will show you some papers to solve these questions. First question, medical complications and complications in the short-term, in the perioperative phase. So in the perioperative phase, we have difference in favor of internal fixation. What differences? Less visits to the emergency department and less anemia. When we take a look on the rest of the outcomes, there are no significant difference in serious medical complications, and we need to take this in account. Second, let's take a look on the reoperations in the short term. This study, it's a large propensity score match analysis focused on young patients. And this analysis group patients in two large groups, a group between 40 and 49 years old and a group between 50 and 59 years old. And in all of these outcomes, we have a significant difference in reoperations and revision surgeries in favor of total hip arthroplasties. I want you to take a look on these two numbers, which is the rate of revision surgery for both groups at 3 years after the surgery. This is a 4.35 against 23.48. So this is a huge difference in favor of total hip arthroplasty. Let's look at the functional outcomes. This is a very large study as well. And this study shows that we have higher satisfaction at 4 months and 1 year with total hip arthroplasty. We have less pain, and we have higher index scores for quality of life at 4 months. So functional outcomes are as well better for total hip arthroplasty than for internal fixation. Then let's look on the long-term results and long-term failures. This same study on almost 3,000 patients from the Norwegian hip fracture surgeries register shows us an enormous difference between the results of internal fixation and total hip arthroplasty. And due to these results, as you can see here, the trends of selection of treatment have been changing. So look how in 2012, it's more frequent that these patients are assigned for total hip arthroplasties or hemiarthroplasties than internal fixations. So in summary, total hip arthroplasty for displaced femoral neck fractures in young patients will result in no clinical significant differences in postoperative complications, better functional results, less reoperations in the short term, and less failures in the long term. So my final messages: there is no current evidence which supports the routine fixation of displaced femoral neck fractures in young patients.
Thank you, Guillermo. Please go to the... Yeah, you have 3 minutes more, so you will have a penalty.
Okay, I accept it.
Finish.
Good.
Okay, thank you. Now, Martin Butaro from Argentina. I mean, it's an amazing presentation from Guillermo with this new approach with total hip replacement in these young patients. So let's see what the audience said, but go ahead with your presentation, please.
Thank you very much. Hi, everybody. It's an honor for me to be here with such a good friends. This is a webinar of new technologies in hip trauma, but I'm going to start, talking about, Well, I'm going to start talking about Gardner's classification, which was born as an alternative to Powell's due to the inaccuracy of this classification. It was born 63 years ago and included only 80 cases, one observer, and only they were assessing the AP plane. Sorry, I don't know what is going on with this. I just pushed once. So let's go back. Gardner classification. Sorry, Oliver, but I just pushed once and it goes all together.
It's your computer, Martin.
What should I do?
Just go with try to push gently. I don't know.
No, I am doing it. So in this paper, all the fractures that were radiographically classified as Gardner type 1 were become in Gardner type 2 when a CT was performed. So the problem is not the treatment, the problem is diagnosis. No. Can I change it through here? I'm sorry, but I think that's the only way. What do you think, Oliver? Can I?
Yeah, pass? Sure. Yeah. We cannot see very well. We cannot see very well. But...
Okay, sorry. Well, so you have to know about the posterior tilt. This has been a game changer. It was described by Baum in 2012. And the patients who present with more than 20-degree posterior tilt are related to a greater shortening, bad results, osteonecrosis, lower functional scores, and a greater need for a second surgical procedure. Maybe this case is a good option for the femoral neck with the femoral neck fracture for internal fixation because the posterior tilt is 15 degrees. But if you see here, this is not a good option because the posterior tilt is 23 degrees. And let me show you our systematic review. We observed in the literature that there was a very high reoperation mortality, conversion, and complication rate in all these papers, but in any of them, the posterior tilt was assessed. So the evidence is every day higher. You're going to have bad results if you don't look at the posterior tilt. Also, let me show you our recently published paper at the JA, where the aims of the study were to see the implant survival in Garden 1 and 2 fractures that were treated with cannulated screws. We divided in two groups, less than 20 degrees of posterior tilt or more than 20 degrees, and we assessed patient survival over time, and we hypothesized that a posterior tilt angle more than 20 degrees had a lower survivorship. Here you can see there were 232 cases, no demographic differences, divided in two groups, less than 20 or more than 20 degrees of posterior tilt. And here you see the big difference, 5% in the patients with a less than 20 degrees of posterior tilt, including all conversions due to osteoarthritis, and almost 50% failures in the group presenting more than 20 degrees of posterior tilt. The failure at 12 months was 5% in less than 20 degrees posterior tilt and 38 in the other group, with a subhazard ratio of more than 8. The survivorship of the patients was similar in both groups. And as you can see here, after controlling for confounders, the posterior tilt more than 20 degrees was the greatest and most significant measure to account for failure. So my advice is, when in doubt, ask for a CT. You can start with, if the patient presents less than 15 degree posterior tilt, with no doubt you can indicate an internal fixation. Between 15 and 20, define it by the Charlson score, ABD and frailty scores. And if it presents with more than 20 degrees of posterior tilt, for sure, the indication is an arthroplasty. My take-home message is that the Garden classification is not useful nowadays, and the problem is still an incorrect diagnosis. The tilt of more than 20 degrees is an independent risk factor for surgical failure. It is really important to have a good cross-table lateral view, but these patients sometimes, or most of the times, arrive to the emergency room at 3 a.m. and the first one who sees is the first-year resident. So the posterior tilt is a clear modifier of this old classification. When in doubt, use CT because it's very useful and it's also a legal tool. And nowadays we are doing less internal fixations because we better study and understand the patients and the fracture patterns. So if you want to succeed, do not replace a femoral neck fracture with a less than 20 degrees posterior tilt. Why? Because you are missing an opportunity, primum non nocere, as Hippocrates said. If you choose an internal fixation that is well indicated, the chances of good results are 95%, and you avoid dislocation, infection, periprosthetic fractures, clinical complications, and in the case you are in the 5% of the failures, the results of conversion THA from cannulated screws are as good as THAs as the initial procedure. Don't talk about the cost, because only the implant, if we compare to a THA, is 10 times higher. So Guillermo, it's not real controversial because you spoke about another subject, but if your less than 20 degree tilt femoral neck fracture would treat it with THA, gets an infection, a dislocation, a periprosthetic fracture, or a DVT, what would you do? Because if this happens, maybe you will need a revision THA. On the other hand, if an internal fixation fails, you can solve it with a THA. So the question I would do is to Guillermo is that if you would indicate the THA to your father or any relative with a real undisplaced less than 20 degree tilt femoral neck fracture.
Thank you. Thank you so much, Martin. You can stop sharing. You have a penalty for not being able to advance the slices properly.
Sorry.
No penalties. No penalties.
No penalties. I mean,
we like our people, and we're very grateful to both of them, Guillermo and Martin. So I think we need to, I don't know if we can afford a vote or discuss a vote or count the vote, but I think the question lies, Martin, do you believe that there is a chance for a younger person, and to Dr. Bonilla as well, I mean, to try to reduce so you can improve the posterior tilt to less than 20 degrees and then fix it?
Of course, and we do it all the time. Less than 55, 60 years old, the trauma surgeons in our hospital do that. And there is no other chance. So the option is that.
So instead of relying entirely on the in situ impaction on posterior tilt, we may try probably to improve the position to get better healing. Then the question moves to Guillermo to ask, is it a cutoff point, the age? I mean, would you go for a joint replacement for the elderly and try to be more conservative for the younger people? Which is my practice. Which is my practice. I agree with it, Martin.
Okay, so
try to preserve the head in the younger population.
So I think it is a cutoff age. I'm not sure what it is, and I that the evidence now does not support a specific cutoff age. I will agree with Martin that there is still a room for doing a close reductions or even open reductions, and to try to improve the position of the fracture before fixing it. But the thing is that it depends on the age. In the past, every displaced fracture in a patient older than 75, we would take patient to an arthroplasty. Nowadays, I think we need to lower that cutoff age, and maybe we shouldn't give that opportunity of a close reduction in a patient older than 55 or something like that. As I said before, we are not sure what's this cutoff age. Maybe in the youngest patient, we need to give them this opportunity, but we need to lower this cutoff age when we just see a displaced femoral neck fracture, and we take that patient directly to a total hip arthroplasty or a hemiarthroplasty.
Well, now you bring the hemiarthroplasty into play. So how much space is there in your practice for hemiarthroplasty anymore in our days?
Not in a young patient. Maybe definitely not. In older patients, now that we have dual mobility components, we have been using less and less hemiarthroplasties. So I think that is not of that use nowadays. However, a couple of weeks ago during the Hip Society meeting, we had a discussion about that, and some people support still the choice of hemiarthroplasties, you know.
Right. I think we need to move forward because we've got another 10 minutes, isn't it?
Yeah. Okay. We have don't worry. We start a minute late, so we have 10 more minutes. So, but we have to do the voting. I mean, for the hour of these two speakers. So, this is for the audience. So please try to vote your best option for this presentation today. I mean, Martin and Guillermo cannot vote. Please don't vote yourself.
Sorry, too late.
It's not the best presentation. It's what is the option? Fix or replace, although both surgeons, both friends, actually follow the same more or less principle. So they replace certain fractures and they fix certain fractures. There's no debate really, but let's say that Martin is presented the fixation option and Guillermo presented more the replacement option, see what our audience prefers.
That's correct. That's correct. Please vote the winner.
We are talking about totally different patients, you know.
Exactly. So it's a little bit misleading.
Yeah.
I agree with everything that Guillermo said.
Try to vote, please. Everybody
and of course, I agree with everything Martina said. We need to fix undisplaced fractures, but we need to do a proper diagnosis of those undisplaced fractures.
Okay, I mean, this is the voting time finished. So, Martin, you won. You have a seat for the Bernabeu Stadium match. So you go and see Real Madrid.
I think we need to reach a consensus. There is no winner here because it's a kind of it's a complex situation. I think we need to agree that if we're dealing with young people, if we have no great displacement posteriorly more than 20 degrees, or if we do, we try to reduce that before fixing, then it is worth trying to preserve the natural femoral head, which is not arthritic. Now, if we're moving to a different age group where there is some evidence of arthritis, there is probably osteoporosis of the femoral fragment, and if we believe that the fixation or the reduction is not going to be great, then we need to move on to a total hip arthroplasty because, as Dr. Bonilla said, we've got wonderful options nowadays with a long survivorship. Do you agree? Do you agree in that conclusion? Yes, yes.
I mean, we don't have time. I'm sorry. We have to move forward. I mean, we have time for
very quick. Syed, tell us, yes or no?
I completely agree. I mean, what I was going to say was, what do you do with a 60-year-old anesthetist who cycles to work? He physiologically is really young, but he's 60. Do you want to replace him? But I agree with your point. If you can correct the posterior tilt, then you've got to fix it. But if you can't correct the tilt, you've then got to have a surgeon there who can do a hip replacement. So you can't have a trauma surgeon who says, oh, I can't replace, so I'll accept a mild reduction.
Okay, Syed, it's your time for the case discussion. You have 2 minutes. 2 minutes left.
Thank you.
You have 2 minutes less. So,
thank you. Perfect. So I'm just going to share my screen. So I'll ask to share. Thank you for the invite, Oliver, and the educational team. I've been asked to share a complex case and which can stimulate discussion. So this is a 70-year-old lady who is generally quite well, independent. She lives in a bungalow with her husband. She has a fall in her kitchen, past medical history of hypertension. She's been diagnosed with osteoporosis 2 years ago, and for the last 6 months has been on alendronic acid. So she comes into the emergency department. An X-ray is performed. You've got the AP and the lateral view there. And the question really is, following the discussions and all the amazing presentations that we've had, how are you going to manage this? Are you going to do a long nail? So we're talking Kefler-Medley, TFNA, PFNA. Are you going to do a short nail? Prof. Tsiridis has told us how DHS has really gone out of fashion, but are you going to consider a long DHS here? Or is there anything else that you potentially want to do for this? So we'll have a poll running, and hopefully we'll be able to see the results of that.
Yeah, let's see the poll, please. Can you vote? Can you vote these options? I mean, from the audience, please. Can you try to vote it? Okay. Any comment from the speakers? I mean.
Yes. Are there any things about anything in this fracture that concerns you from the panelists, our expert?
For example, Luigi, are you there?
Well, this is a reverse.
Yes, I'm here. It's a reverse. Yeah,
reverse fracture. It's a reverse obliquity fracture that there is straightforward answer to what kind of intramedullary device you should use.
I mean, all the people vote the long intramedullary nail.
Of course.
So do you agree with
that? The majority agree.
Yeah.
Agree.
So 76% of people said long nail. I agree with that. So that's essentially what was done in my unit. So I came in on the weekend, had a trauma fellow operator. So this is a long PFNA that was put in. I'll show you another image. So any comments here, panel, about the fixation?
Professor Sen?
Or criticisms?
Yeah. Professor Ramesh, any comment about this option?
No, that exactly is the option where it has to be a long nail and it has to be locked because we are unsure about the stability at the fracture site. So it has to be a locked long nail.
So this is a locked long nail. Any criticisms about this? Would you be happy if this was done in your department? I mean, it's well aligned.
Yeah, this looks to be well done. The only problem is that because it's not a primary, a traumatic kind of an injury in a normal person, there are other issues. So we may have to keep our fingers crossed about the outcome.
Yeah, so you want to monitor this closely. I agree. Any other comments from the panel?
Martin, any comment?
Oh,
No? Good. Okay, so we move on 2 months post-operatively, and this is what happens. So she's actually sent home, walks with a walker frame, comes back at 2 months. She doesn't have a follow-up before that, because generally in England, we tend to discharge our neck or femur fractures without follow-ups routinely. So it's not picked up. This is an atypical fracture. So 2 months later, she's back, severe pain, unable to walk, and this is what we're left with.
Guillermo,
So could someone have predicted that from this?
yeah, Guillermo, any comment on that?
No, not really, Oliver.
Okay.
Maybe the fracture can be, there is a diastasis between the fracture.
Yeah, so I mean,
Compressed bit.
yeah, so I mean, there's a distraction there. It's not
Yes.
completely compressed, and because it's locked both proximally and distally, it's not really going to dynamize. I agree, Prof. Zagra.
Well,
So-
someone may say that this is a fracture to exactly the same fracture line. That leads to the conclusion that probably, although on the AP and the lateral view looks that there is a kind of an adjacent fragments, probably there's a rotational component hiding or malrotational component hiding somewhere there in the obscurity of this cloud around the lesser trochanter. So probably there's some sort of a rotational issue, but maybe not.
Yeah, potentially, I agree. So she now turns up. Obviously, all the metalwork needs to come out. The question is, what are you going to do?
Yeah, say one comment from Professor Johannes Bastian. Sorry.
Of course, sorry, I didn't see that hand raised.
It is not a comment, it's rather a question. So what was your aftercare protocol? Was you allowed for full weight bearing as pain tolerates, or did you restrict that one? And was she an obese patient?
So there was no restriction post-operatively. So she was allowed to mobilize fully weight bearing, but she was only able to mobilize with a frame. So she was using a Zimmer frame to get around. And in the 8 weeks between being discharged and coming back with this broken nail, she wasn't able to walk without the frame. So she was only able to walk with the frame.
So let's see the next question. Yeah.
So at this stage, do we think this is purely to do with the fixation technique? Is that, what do we want to do next? So we then investigated her to make sure we ruled out infection. So her wound site had healed well. There was her inflammatory markers were all normal. So this clinically and on blood markers, no infection. So what do we want to revise this to?
So how do you see the options then, Luigi?
I would fix with the plate.
Plate?
Plate, yes.
Professor Sen, plate as well?
Yeah, that's true, because right now we need a stability across it. It cannot be, so it has to be with the plate fixation right now.
Okay.
So we
Guillermo?
want to go for absolute stability. I agree, fine. Okay.
I will go for the plate as well.
Okay. Martin?
The trauma experts in my hospital would do a new intramedullary nail.
Nailing, yes. Yeah.
Okay.
Okay.
And Johannes, your option?
So the standard of care for the AFS fractures is intramedullary nailing. I would never go from a nail back to the plate. Besides plate plating or double plating, I would rule out infection, and I would give some osteobiotics to the fracture side and go for a bigger nail, and maybe add cerclage or a small plate to have a plate-nail combo.
Plate-nail combo, amazing. Eleftherios, your time.
Although we say that when a fixation method fails, you need to change, I wouldn't really go to that much metal because I worry about the biology there. So I would redo the nailing. I would open the fracture site. I would do a proper reduction with some circular wires. I would add some biology like bone graft, and I would re-nail this fracture with some bone, some autograft from the pelvis or elsewhere, probably using RIA from the other side or from the same side as well. So it's an opportunity to RIA remit, get some graft output on the fracture side, re-nail it with good reduction.
Amazing. So the audience vote mostly for revision intramedullary nailing of the femur.
But quite split across the board. And you can see that's the discussion that we had. And I agree with Prof. Tsiridis, what he says, that there's no attempt here for it to heal. So there's no callus formation to 8 weeks. So revisiting the biology and putting bone graft in, that would be a good idea. And that what was done. So they decided not to re-nail it, despite there being a discussion about it, and went for a long DHS. Absolute stability. So you can see that the screws that go across the fracture site to try and get absolute stability. There was some bone graft used, and not vascularized bone graft, just cortical strut graft to fill the space. Happy with that?
Was it open or through a minimal invasive technique?
What was that? Sorry, Prof. Zagra.
An open
technique. Open technique. Fracture site was freshened. Cortical strut graft cubes were used, and a long DHS applied. And 2 months later, that's where we're at. And
what
then
do you think, Professor Sen?
I'll go back.
Sorry. With this view, Professor Sen, what do you think? 2 months after 3-4 surgeries nearly? What do you think? Did you see this X-ray in your clinic at 2 months?
I mean, there's a little doubt on the medial side of it. So I have to be a little suspicious about that doubt appearing, a gap appearing over.
So at this stage, she's still walking with the help of a Zimmer frame, not able to walk independently purely because of the pain at the fracture site. So on this occasion, she's not discharged. They want to keep an eye on her. So she comes back at 3 months, and you can see there's some callus formation now. So still not walking great.
So
does anyone want to do?
Let me ask Johannes, because he said a nail. So what do you think about these X-rays at 3 months?
I mean, this is only an AP view. If you are in doubt, you could go for CT scan, depending on the fracture healing. So you see there's some rarification of fracture lines, but there's a lot of stress at the medial side, and I'm wondering about the compression because the DHS is doing nothing for the proximal part. It's an almost subtrochanteric fracture part here. So I'm concerned.
So your concerns are completely correct, Johannes, because of the method of fixation. But what is the CT scan going? How's it going to guide you? Are you then going to intervene if a CT scan shows that there's no healing there?
Nothing, because it's too early after 3 months.
Okay, so you're just going to keep an eye on it.
If you want to get more information, you could ask for CT scan, but I wouldn't. So if I would have decided to go for this type, you have to wait more than 3 months. Let's say another 2 months, depending on the situation of the patient.
Okay, so we're there at 6 months. You can see a lot more callus formation at this site. She's now walking on it slightly more comfortably, but is using crutches. She's not able to go back to walking independently, which she was doing prior to her initial fall. But with these x-rays at 6 months, she was seen in a trauma clinic, fracture clinic, and they said, fracture's healing, we'll carry on keeping an eye on it. Happy?
Did you stop the bisphosphonates, and did you do an osteometabolic workup in the time?
So her bisphosphonates were stopped after the first failure, yes.
Mm-hmm.
But she's on calcium and vitamin D supplements at this stage.
Yes, she's improving, but we do not know
So
if there's a defect size, a large defect size. We do not know without a CT scan. But she's improving, so go on.
Yeah, so clinically improving. She's stopped using a frame. She's on crutches. So she's then sent away saying, we'll see you in a year's time. Yeah. At 8 months, she comes back. This is when she's referred across to me. And I'm now catching up on everything that's happened in the last a year or so. So initial operation, nail, failed. Second operation, and now failed. What do we want to do now? So that's where she started. Failed nail. And now we've come to this stage where she's got a broken long plate THS.
Oh my God, it's now different options: revision nailing, revision dynamic hip screw fixation, proximal femoral locking plate, or total hip arthroplasty. So people.
So again, I investigated her to make sure I rule out infection. And so no clinical signs of infection, inflammatory markers, CRPs are all fine. This is a failure of our fixation.
Luigi, do you do another fixation here?
I am an arthroplasty guy, and I want to go to an end of the story. So we go with the review.
That's the reason because I asked you.
Top of everything. Top of everything.
Professor Ten? Ramesh?
Yeah, I don't know. I'll still try to make another, because I told you there is a preponderance for it to go for a non-union. There has to be a reason which need to be defined it out. And especially the kind of a fracture it is, the area is usually not a very viable area. And if you are fixing a non-viable area with any device, it is likely to fail. So we have to be really careful about this area. And if we found it to be good as this, infection was one possibility, but if it is ruled out, again, I'm a little skeptical about the viability of this area. I don't know at the time when it was done, how viable were the bones around.
Guillermo, what's your opinion now?
Yeah, I think that this is a very difficult proximal femoral replacement. This is a surgery with a high risk of complications of adverse events. So in this conditions of a good bone quality in the femoral head and the neck, I will try again a fixation.
Okay. Martin?
No, it's only 2 shots for these patients. When the second shot fails, I go for a revision.
Great. So honest. Johannes, you think?
I would have done a second revision of bigger nail with dynamic compression. And it's hard to say how to proceed now. But at the end, if you want to go for arthroplasty, you should go for a modular stem, because this will not heal here. And you will be in trouble to get the crater trochanter fixed and healed from the adductors. And for that, just go for double mobility cup to avoid another surgery, revision surgery with dislocation. And rule out septic non-union.
Yeah, interesting. Eleftherios.
That's the discussion that I had, actually, because I'm very keen to convert any of these failed fixations to total hip replacement. But in this case, I was concerned about what I'm going to do with my proximal femoral bone stock if I convert it to a total hip replacement. Any other comments before I move to what I did?
And probably not.
The options were the plate fixed to the proximal part of the modular system, like the active stem from Marin-Peña. You can fix it and compress it, and you can give some bone graft to the defect, but it's an issue. Are you using a small LCP plate banded?
We've got proximal femoral LCP plates. Yes, we do. Yeah.
Luigi and Eleftherios?
No, I was just commenting that you don't need to replace, of course, all the proximal femur. You just need to go with the revision stem using distally of that.
revision 7 distal locking, yes, yeah, potentially. So I had a long discussion about this in our trauma meeting and discussed it with our local trauma unit. And what we decided to do is what Johannes suggested, which is a revision nail and a proximal femoral locking plate. Revisited the fracture site again, freshened it up, used an iliac crest bone graft on this occasion, a vascularized bone graft. 2 months following revision, that's where she's at. So very stable intraoperatively. I got her walking on it, fully weight bearing again with the frame at 2 months. Considering how independent she was very unhappy to be using a frame again. 6 months post-operatively, that's where she is now, and walking with the help of one stick. So she's a lot more independent, and all looks like it's finally healing.
Wonderful.
Any comments on that? That's something Johannes had suggested with the first failure. So he had said with the first nail that had failed that he'd do a revision nail and fix it. And I suppose that's what should have been done initially.
The plate faded 2 months later, correct?
Plate will fail.
So we have to wait 2 months more.
2 months more. 8 months, yes.
And now, sorry, Jordan.
Thank you all of you for this fantastic discussion. I mean, we need to go to the end of the webinar because exactly we have now 1 hour and a half, 90 minutes. So I really appreciate all your collaboration with the webinar, all the very nice discussion and very hot discussion sometimes. And the opportunity to Professor Tsiridis to do the wrap up of this webinar. Eleftherios?
Well, it's a wonderful opportunity to get together very good friends from all around the world and give these fantastic lectures. I have to say that there is an amalgamation of experience, knowledge, and academic which all comes together in our webinars. And we got all three components together. I'm really grateful to all the speakers. I need to announce our next webinars, hopefully the end of June.
20th of June.
20th of June is going to be
same time
on hip preservation. Hopefully, the 19th of September on primary THA, and hopefully before Christmas. No, the date yet is going to be on revision hip arthroplasty or similar. Well, I'm really grateful to all of you, to your expertise and your devotion to the Hip Society, which I have the honor to chair next year. Thank you very much all for attending.
Thank you, all of you. I'm sorry.
Thank you. Bye-bye.
All the questions. Bye. Thank you.
Okay, bye.
Thanks.
Thank you, Guillermo. Thank you, Maziar, Martin.
Thank you. Goodbye. Thank you very much.
Thank you, guys.
My great friend, Luigi. Evening, Oliver. Well done. Yes, well done.
Let's see the numbers.
Don't worry about the numbers. The quality matters. Quality matters. Numbers will build up.